All right, welcome everyone. Thank you so much for joining today's virtual telehealth panel that we have for you today. This session is being brought to you through collaboration between the LCPA and the Louisiana Health Information and Management System Society. We have a great panel for you today. Panelists who will be able to provide really nice insights both from a provider as well as a payer perspective. We encourage all of today's conference attendees, please submit questions to us through the messaging feature, and we'll try to address those the best that we can during today's panel. My name is Paul Douglas. I'm a consulting director at PNN, and I'm currently serving as president for Louisiana HIMSS, and I will be your moderator today. Prior to jumping into our first question, let's start with introductions and get to know our panel. Jen?
Sure. I'm Jen Humbert. I am the Assistant Vice President in Telemedicine here at Ochsner. I have been with Ochsner for the past 6 years in telemedicine, working as the leader in our development and solutions and virtual hospital services. So I work with our system service lines across our system to help them design and develop their telehealth programs. And then also have oversight. We have an EICU and a remote telesitter program as well that I oversee. And total years in the telehealth space, I've been in the telehealth space about 10 years. And I am going to hand it over to my partner here at Ochsner, Sarah.
Hello, everyone. I'm Sarah Chandonnet. I am the Assistant Vice President for our Digital Consumer Experience team. So I am the IS counterpart to Jen and multiple other business areas that really need kind of IT support for their digital health programs. So I have oversight over kind of digital medicine, telemedicine, our MyChart app, and work a lot with our system leaders on their patient engagement and digital strategies.
Good afternoon, everybody. My name is Brian Taylor. I'm a nurse practitioner. I'm also a telehealth and digital health operations manager at Blue Cross of Louisiana. I've joined the Blue Cross team back in 2014 and started with telemedicine, both the implementation of a platform and many of our policies that cover reimbursement, member benefits, and those sorts of things. So like Jen, I think I've been here probably at our inception of telehealth and then watched it evolve through to today. I'm still a practicing nurse practitioner, so I try to bring a little bit of that in with that project experience, but act mostly as helping with subject matter issues.
Brian, I think the official term is telehealth dinosaur now.
It absolutely is. We are fossils in this business today. That's good, though.
Well, that's wonderful. Well, thank you so much for serving on our panel today. And to get things started, I wanted to first start by asking you all, can you describe to our audience here your organization's current approach to telehealth, the services that you guys are delivering through telehealth, and also what did that shift look like for you all from 2019 to the current state?
Can we go into rotation?
No strong preference. However, we can organically jump into things here.
Jen, I'll let you lead off like we did last time. That's perfect.
Sure. So we were fortunate here at Ochsner. We actually got our telehealth start back in 1998. So we had been doing programs back in 1998, and it actually started with a pediatric echocardiogram program. So we, like many other organizations through the years, continued to evolve those programs, really took the foothold in 2009 with our telestroke program, as many of us saw across the industry in the telestroke world, which really kind of gave us that we like to consider that the gateway drug into telemedicine, or used to consider it that, and then and really continued to evolve since then. In 2012, we launched our remote inpatient monitoring programs, or what we call our virtual hospital services now, which is EICU. In 2016, we continued to expand on those programs. In 2018, we started and got our launch into the direct-to-consumer space. So between 1998 and 2018, we really grew our programs where we were faceted in every channel and space within telehealth, whether that be hospital to hospital, clinic to clinic, or into the home space in 2018. And then in 2019, really saw the adoption in the telehealth space, and really specifically more adoption in the consumer space than we had ever imagined. That really came out of the COVID pandemic. And I think about that from a telehealth perspective is that, we had the ultimate tool in our space to combat the pandemic. So whether that, if our major defense against this virus was decreasing exposure, audio video access facilitated that. So it was really our opportunity to capitalize in our space. So Sarah, I'll let you add to that.
Yeah, I would say for us, it's keeping up with Jen and Jen's team and everything that we're doing, and making sure that we are providing a really stable and scalable technology solution, both within our organization and then outside to our partners that we're delivering this care to. The big shift between 2019 and 2020 was in the business of scalability, like making sure that we have all of the right platforms in place and all of the right monitoring systems available to ensure that every experience with telemedicine is a positive one from both the patient and the provider perspective. We're not pushing adoption anymore. We're just ensuring that those folks that we're asking to adopt are having the best experience, and they want to come back, and they see this as kind of a normal part of how we deliver care in the future.
Yeah, I do want to give a shout out to the Ochsner folks. They really were prepared, and that's kind of part of all of this. So as COVID hit, you asked about what we had going on pre and sort of post COVID. Prior to COVID, here at Blue Cross anyway, we've really had two approaches to telehealth. One has been, we wanted to bring the capability to areas that may not already have it by launching a platform that would give our members 24-hour access to episodic telehealth, and then very recently behavioral health. And then we've done that through a partnership with American Well and launching a platform called Blue Care. And that's been live since August of 2015. But we really haven't seen most of that utilization, probably like Jen was referring to, until recently, where direct to consumer is becoming more and more available, and knowledge, that knowledge is out in our member base, which brings us to that second prong. In addition to having a platform, we have to have a benefit. So for our members to actually receive telehealth services, we had to create that benefit back in 2016, which helps drive things like reimbursement policy. So, the folks over at Ochsner can do that piece and deliver those services and be reimbursed for it. So anytime we do things at Blue Cross regarding telehealth, it's really talking those two fronts. We have the platform, and while we want to maintain that, we also want to support the network in innovating their own solutions and bringing them to the member. So fast forward to COVID, and what we saw was, just as Jen said, and everyone else. And what's funny is, we always heard this before. Jen, I know you've heard this, is that we're not going to call this telehealth anymore. It's just going to be medicine. And COVID fast forwarded that concept, I think, to where we are right now. Is we fast forward about 5 years and 2 months. And we're at that point where telehealth is just ubiquitous through all medicine. Just to give you some scope, though, you asked about how the shift changed. Big shifts happened in our reimbursement policy. We went from, a few limited provider types to a large number of provider types. We went to some limited telehealth direct-to-consumer services to a very large amount. We included audio only, and including AV. And there's some other things like that you'll see with COVID. Will they all stay? There's likely to be quite a bit of it that stays, but then, even CMS is sort of reevaluating all that. So that evolution is still going on and will continue to go on, I think, as long as there's a public health emergency. The shift in utilization was very interesting. And here at Blue, I'm sure Oshner does it too. We are always about data analysis. So if we see any shift, we start analyzing the data the very next weekend. So when COVID hit, I shared with you, Paul, in a conversation, we saw some gaps that sort of, or not gaps so much, but we know that in-person visits fell off quite a bit. And we deal with those visits sometimes in visits per 1,000. So just to give folks an idea, in March, we had a 16 visit per 1,000 drop in in-person visits and a 3.5 increase in telehealth per 1,000. That's not closing the gap. That means overall, those are services that weren't delivered in 19 but not in 2020. So we're kind of curious, well, what are those gaps? Where are those services being missing? And then when you go into April, you see similar. We had that 16 visit per 1,000 gap increased to 44, going from March to April. That's about a 61% decrease in inpatient or in-person visits overall. Telehealth went up to 10 per 1,000. So that's a 34 per 1,000 visit gap in person. So while we think we were poised and ready to meet the demand, we clearly are not. And the providers who were surveyed, outside of the folks like Oshner and those who were well prepared, gave us a lot of reasons for that. Those who weren't early adopters, stepping into this space comes with a lot of learning that Jen and Sarah can tell you a lot about. There's workflows, there's technology issues, and then there's patient issues. One big thing that came back from the providers that was interesting was they started having, and these are smaller providers, they would start to have to increment their visits to 30 minutes instead of 15 just to account for that patient side and education. So the moral of that story is I think the gaps will close, but the gaps will only close as utilization within the network increases. And as a plan, the way we spur that is through working with them on, reimbursement policies that work for them.
So Brian, building off of that, might be a good time to jump into the quality question. I know historically that has been a little bit of a barrier. How can we ensure the quality and the clinical documentation that's necessary for the services we're trying to deliver virtually? So I'm interested to hear from you all. How are you ensuring that the services you are moving into providing through telehealth, that you are protecting that quality, and what kind of efforts have you gone through around clinical documentation and standards?
So, Paul, these are areas that we have been focusing on literally since the beginning. And if I think about how we're shifting, and really specifically even in that consumer space where we've seen like this huge rapid adoption, and now we're on track for 270,000 consumer visits this year within our organization, I kind of bucket it into optimization and sustainability, and we still have to ensure that we're closing the gap on the change management process. So maybe what works during crisis mode or what we did in crisis mode isn't necessarily going to meet the needs, long-term in sustainability. And this gives us that foundation to truly optimize and reinvigorate the secret sauce of telehealth. So we continue to optimize with our providers. We have several drive teams across our organization looking at virtual visit optimization and quality oversight. And that's inclusive of a multidisciplinary team. And actually Sarah's team really leads that up with us in partnership with Epic. And then really working with our providers, understanding their pain points. And now that we have a very large group of physicians that have gone from novice to expert in telehealth, and if you've ever worked with physicians across, or any provider across the board, there's no shortage of feedback or no shortage of wanting to ensure quality within their programs. So now we have a very large group of clinicians that have really transitioned from novice to expert in the telehealth space. And they are really driving and reinventing our innovation and really helping us break our fixedness and truly allowing them to be at the forefront of their practice and helping us drive those quality initiatives along with our legal and compliance teams as well. And Sarah, I'll let you pick up on some more. I'm sure you have more to add.
Yeah, I would say one of the things that's been really interesting to hear from our patients is kind of what makes them continue to feel comfortable with telehealth. And what they've said to us is, well, I feel comfortable if my provider recommends it. Okay, so then we go back to the providers and we say, well, what makes you feel comfortable recommending a telemedicine visit for this specific patient type? And so what we've learned is that it's not a one-size-fits-all model, and we really have to hear from our providers about what types of patients make the best candidates to deliver that high-quality care, what types of patients aren't the right candidates, that they would prefer to divert them to in-person care, and then what tools can we offer to kind of increase the comfort with telehealth. So is that the ability to share a screen? Is it the ability to invite a third party or a guest? Is it the ability to have a video provided to the provider in advance of the visit? So we're hearing a lot from the providers about what types of features and functionality that we need to adopt and enable for our patients and our providers in order for them to deliver that quality care. Like, they're not going to be comfortable delivering the care unless we can meet their expectations for the functionality that provides that high quality. So like Jen said, we're talking to our providers, we're out there, we're hearing what they're saying, and the direction we're moving from a technology perspective is in line with what they're asking for, so that they can continue to encourage the patients to take advantage of the telehealth services. So it's all very cyclical for us right now.
Quality is a constant conversation over here at Blue. I think everybody at Ochsner is kind of familiar. We have, lots of programs and standards in place. There's really sort of a two-pronged effect to approaching quality. One is an analysis of, what's being delivered, looking for those outliers and things like that. And that's a piece of it. But then with telehealth, we have not quite a specialty, but it almost is. So there are folks who are trying to get into this space and not always the best players. We have a fine example with us today, but part of what we do at Blue Cross is, like most accountants, it's stewards of your money. We want to make sure that it's being spent on a quality product and quality care, and you're benefiting from it and you're not being put in danger. So, the folks like we're talking to today don't really have those kinds of issues. But when we get into, some of the telehealth only space, there can be some questions about that. So there's a few things that are put out to help mitigate that. Recently, URAC bought a company called Clear Health Challenges, and they've put together an accreditation program. So that would be a fine example of, if you were a provider in the space, or you were a system, or you were, maybe you weren't a single provider, but larger, that would be a fine example of somewhere to go to start your quality program. And it's well defined, it's got modules in it, and it basically, there's a process to take you through that accreditation. And I think as we move through telehealth and we have more players, that question's coming up over and over at the legislative level too, is where are we baking safety in to this new mode of delivery? It's not quite a specialty, but then it's not exactly not a specialty. If you're adopting it, for example, Paul, we talked about mid-levels. That's a very prime area for abuse. But then there are standards in place that are already there, and part of it is checking on those too. So, the LA Nurse Association, they have their own guidelines around collaborative agreements and ensuring, for example, that if you're delivering virtual services, you're collaborating with a physician partner who is knowledgeable about delivering virtual services. Those are already in place, but then I think as we evolve, they're going to see more through things like URAC, maybe ATA, and some others. And we'll be looking to those standards probably as we talk about network providers who are maybe delivering telehealth versus telehealth only providers trying to become part of the network, if that makes sense.
Yeah, and we have a question that came in. I think, Jen, you were the one that had mentioned kind of the average visit being 30 minutes for what would have normally been a 15-minute in person. question came in just wondering what was the driver behind that 15-minute increase, and do you suspect it had to do with individuals preferring to be in person versus having the visit through telehealth?
I think I might have brought that up as feedback from one of our providers. That's not related to. So I don't know that Ochsner has the same issue with workflow that this provider shared with us, but this would be a smaller practice, independent practice providing telehealth, and her feedback was her workflow shifted because she had to aid her patient in using the virtual service oftentimes. So while they might try to make that AV connection, it would fail, then they do a telephone call, and that's where that additional 10 to 15 minutes came in usually. Troubleshooting.
Yeah.
Yeah, we definitely during the COVID increase, and I empathized with Sarah and her team. They felt most of the brunt of it. There was, as patients were adopting and using telehealth for the first time, that was one of the things that we directly had to respond to was the technical support needs. Right. And truly, the platforms are very, very simple to use. That's part of our design principle is ease of use for our patients, but still, at the end of the day, there are that component. I think we were fortunate that we had some good infrastructure in place to where a lot of that burden didn't fall onto our providers. But from our provider perspective and our patient perspective and the experience during that visit, what they're finding is that they're able to the patients and the providers feel more focused time together. And during that more focused time, it's a more valuable interaction and almost sometimes decreasing the time that they spend in the visit, but still getting more output. And some of that may come from if a patient travels in to see their provider, sometimes they feel like they need to get a lot more questions answered, or if they took the time out of their day or took time off of work to go and see a provider in person, they feel like they need more time with their provider other than that focused video time that they have with their provider, and it's actually more efficient and we get more questions answered during that time than sometimes that feeling of I feel like I have to address these 10 things because I took time off of work to come in. So it's very interesting to see how that is playing out, but we are actually able to see our patient satisfaction scores feeling that the interaction was very personable and efficient and getting all of their needs met.
Right, and to Jen's point, it's about numbers. We see 300 to 400 visits on Blue Care for Medical a month, and if only 5% of those have a problem connecting, that's not an insignificant number to try to troubleshoot and offer service. So you have to account for those kinds of things. And then that provider's feedback was it's a learning curve. She's 30 minutes now, but as she adjusts her workflows and things, that'll get better.
Oh, that's great. Great insights, firsthand experiences that you all are sharing. For our CPA crowd, the accounting and finance folks in the audience right now, I thought we could maybe talk a little bit about the cost side of this and also the value. So in your experience delivering telehealth services, and I guess Brian, in your case, reimbursing for telehealth services, where are you guys seeing some of the major cost drivers, and where are you seeing the highest value where you're actually receiving a nice return potentially on some of the services you're offering today?
Jen, if you want to start her. So you go ahead, Jen. I'm sorry.
So I think there's a couple pieces of the prong to that question, and where we're seeing some of the highest value in telehealth. Again, it's not a one-size-fits-all across the board. Just the same as kind of the quality conversation about appropriateness for patients. And our approach to telehealth and our approach to innovation is always to start with our pain points and what problem are we trying to solve for. So if we understand the pain point and the problem we're trying to solve for, whether it's for our provider or for our patient, the value in that program can become very different. So the value in the programs, in our consumer space are very different than the value to our programs in the hospital space, but equally important. I think about that in the sense of the COVID crisis. And when we went in, we were like, we need to triage patients. We still need to care for them. We need to decrease exposure and prevent them from coming into our facilities. And our data showed very much in alignment the increase in virtual visit volume that was right in line with the increase in our COVID cases. And we were appropriately triaging and keeping patients in virtual urgent care and virtual primary care. But we also had to take second things second and really look at that approach on our inpatient space as well. And the value in that space was our ability to, we had areas where we had hot spots in New Orleans where our providers were completely overtaxed, and then providers at other campuses distantly that were in lack of work. And so as we were reappropriating staff, we were able to use telehealth and the audio video access as kind of the equalizer and the load balancer to some of our staffing models, specifically in hospital medicine, where we were able to care for patients on a virtual hospital service and load balance across our system. And so the value there, it's interesting. It breaks the fixedness. It wasn't a rural location. It wasn't an underserved population. It was truly in our New Orleans area, and we needed, at our main campus, and needed to use telehealth as the equalizer to load balance to be able to care for our patients across the board. That value was just important as our value in the consumer space as well. So as we have that approach as telehealth as a tool to facilitate care, and it's on us to ensure that we are proving the appropriate value and metrics of success in those areas, but we're seeing equal value in multiple spaces.
Great.
I would ask from an IS perspective, the technology infrastructure is not inexpensive by any means. I know that during kind of early COVID crisis, we happened to have the technology infrastructure that we needed in place. We had made those investments years ago, as Jen said. It was really important for us, though, that we evaluated our telemedicine video partner to ensure that they were going to continue to grow with us. So telemedicine video platforms, they're converting from really a cost per user to a utilization model. So the more that your providers are comfortable using it, the more use cases that you develop, you're being charged for utilization, but your infrastructure and the dollars to support that infrastructure really drive those use cases for utilization, and you want to encourage more of it within the organization. The other thing I would say is we talked a little bit about, and Jen touched upon, kind of the need for patient technical support. There's also a need for provider and staff support. So kind of some of those hidden costs, that they drive value, they drive adoption. So we have quite a large patient technical support team. So like I said, if you don't invest in having those resources available to your patients and they have a poor experience, that time is going to shift from the patient time where they could spend with technical services to the provider's time where they should be caring for the patient during the visit. So it makes sense to make those investments in the areas that are really going to take away from the clinical visit. So you want to make sure that you have a very stable platform. You want to make sure that you're driving everyone through a single front door to make it super easy to access your video services. And then you want to make sure that you have the support services in place to ensure that everyone's experience, patient and providers, continues to be positive.
So for us, the cost question is probably, the jury's still out a little bit on that, but I can tell you where we're probably looking at where cost was impacted. So obviously, with isolation being supported by telehealth, both policy and a platform, the goal was avoiding inoculation of new COVID cases. So, the intangible cost right now of that, we're not certain, but we're probably going to, hopefully look to our folks, our network partners to help us, tabulate maybe or put a number to that. But also there's a cost with not maintaining care. Chronic care, behavioral health, preventative medicine, all of those things, by avoiding it, come with a cost. So implementing telehealth reimbursement strategies that support that while in isolation, I think was key to help and keep those costs contained. But you asked about one single area, and if I had to pick one, behavioral health sort of wins hands down through this whole thing. Number one, we had a flex in demand with COVID and isolation and job loss, and the multitude of mental health issues that come along with it. Fortunately, I think a lot of folks, including our own platform, was poised to meet some of that demand. We launched our behavioral health in April, and we quickly caught up to our episodic medical volumes on Blue Care. And then when we look at in-person versus telehealth claims, there were much smaller gaps in what was left between in-person and telehealth. For example, in March, there was pretty much no gap. We had, a decrease of 1.2 per thousand behavioral in-person patients, and we had an increase of 1.6 on the telehealth side. So that was, if anything, we made up for the gap with telehealth. That continued on through April and May we averaged about maybe 1 to 2 visits per 1,000 that were not getting done between 2019 and 2020. So I think it was a good example of how telehealth in behavioral health space stepped up and met a lot of the challenges, maybe not all, but very close to what we were seeing in 2019 and able, hopefully, to keep up with demand. I think some of that is going to be remains to be seen then.
Okay, great. Well, I know another hot topic out there related to telehealth is what can we expect from a legislative perspective? I know at the onset of the COVID-19 pandemic, a lot of requirements were relaxed to help enable the adoption and the rapid adoption of telehealth. And we're kind of in this awkward place today of when are they going to roll back some of these? Are they going to implement new legislation to help ensure the success of telehealth going forward? So very interested to hear from you all. What are your views on the various opportunities that are out there, and what do you think needs to happen? I know you have a lot of views on this, Jen. Don't be shy.
I was just wondering where we were starting.
Well, jump right in.
So yeah, a lot of the friction and the barriers to telehealth adoption prior to COVID were a lot around regulation, licensure, reimbursement, and it did create a lot of friction for adoption. And what we saw is, so there was the crisis moment of a pandemic, but then the reduction in all of the friction that was created in that space. And I know that CMS has, during the public health emergency, we have commitment to continue all of the waivers that are in place, but we don't know what's going to happen after that. And I think that some of the key points is for us to think about is that telehealth truly did become a differentiator in a space more than just only in that space of just access or rural communities. So I think some of the biggest things that we advocate for is that the location restrictions won't come back into play. And whether that location restriction is home or that location restriction is in the city of New Orleans or in a rural area, because the health disparity, the needing to reach the patients, and the need is there irrelevant of where that patient location is. We really started to think differently about telehealth, not only in just reaching, places that maybe don't have stroke care, but really did start looking at this within our organization on how to create efficiencies in our staffing models to be able to serve more patients and to be able to provide the care that we should be able to provide and have more frequent patient touches. And I think that and to be able to care for the patients holistically, in a way that we truly want to. So not having those barriers put back into place, and leaving those barriers of friction eliminated for us. I do know there's a lot of talk about multi-state licensure and state compacts. During the public health emergency, we had waivers, but each state was still able to determine how they wanted that waiver implemented. So, whether we were going to practice in Mississippi or Texas or another state, we still had to follow those state guidelines. There was just a lot less friction in order for us to get there. And I think that those are the keys to it, to not take away the autonomy of the practice of the different states or the different medical boards, just as we want everyone to protect, we want everybody to respect our LSBME and our nursing boards and our boards of professional practice. We still want them to be able to govern and oversee quality, but also then do it in a way that can reduce the friction. And we were able to see that take place during COVID.
I don't have too much to add on that. I would just say that for the lax in the regulations, the thing that helped us is that it allowed us to scale really quickly without having to put too many boundaries into our provider workflows about what they could and couldn't do. So, I mean, we know that it's not always going to be that like waiver world. So we do work really closely with Jen's group to make sure that, where we can standardize, where we can build stops into our provider workflows to make it easy to keep them compliant. We'll continue to watch, but we've definitely appreciated how quickly we can deliver kind of the services to the providers and expand their capabilities because of the lack of some of those more, more detailed regulations that are difficult to work within.
I think before COVID, I'll go out on a limb. I believe we were pretty forward thinking in some of our reimbursement policies prior to. Jen had mentioned the location restrictions. We've never had those location restrictions for our own direct to consumer. So since 2016, you've been able to do that, or at least our provider network's been able to do that and get reimbursed. The services we reimburse for are typically reimbursed at the same level as the office visit as well. So payment parity, at least at this point, hasn't been an issue again, because I think we wanted to incent telehealth and not, punish someone for trying to adopt new technology or innovate. Some things came into play, or at least discussion through COVID, that may challenge some of that. So, we talk about legislation, and legislating parity for telehealth is not anything new. It's going from state to state. But one of the things that I think is important to recall when we do this is sometimes we move away from flexibility in payment, and we opt ourselves to get back on a treadmill for volume. So while we agree with incenting it, we also want to incent the use of telehealth through payment in other ways, like quality payments or payments for performance, and utilizing telehealth or digital medicine in those spaces. Another area is security. So OCR, they lifted restrictions on security to allow for folks to enter the space that maybe weren't contemplating it before. I don't see that as a lasting change. I think that will be rolled back quickly, because if we took that approach to the EMR, I think we'd all know that'd be pretty disastrous. So there are those things that we're going to go ahead and agree with probably, but we'd like to work more with our partners to talk about things like payment and the legislation. So these are good forums to have, I think, and these are good subject matter experts, I believe, for those kinds of conversations when we go to legislature.
And it's a great point around security, Brian. Historically, the HIPAA security rule and its various iterations with the Omnibus ruling and the HITECH Act, it still lacks that level of prescriptive security detail to really help guide the provider and the implementer. I know the National Institute of Standards and Technology, they've put out a telehealth security guide. So it'll be interesting to see if, someone such as OCR, who often does rely on the publications from NIST, if they will put forth something like that in future legislation. But today we didn't have the best prescriptive guidelines around security to begin with. And so, relaxing the privacy requirements certainly helped a lot. At the same time, we have new interoperability laws going into effect, which also complicate privacy or help, depending on how you look at it. So it's certainly an area it'd be great for HHS to weigh in on. So I have one last question. I'll make it an IT related question, unless there are no more questions from our audience here. So last question around IT. Sarah, you had mentioned scalability being one of those big investments and critical challenges. Brian, you brought up security. We haven't covered the actual device side of this. And, I'm interested to hear from you all. A lot of, certainly the smaller providers, they may be delivering telehealth through their iPhones, iPads. I'm interested to hear from someone who's advanced as Oshner today. What technologies are you using that, you think are here to stay? And where do you see the need for technology innovation?
That's a great question. So for us with scalability, what we try to ensure is that front door experience in driving all of our patients through Epic as our EMR is really important for us. It's really important because we can't manage inconsistency. And if people are having technical challenges on either side and they're not using these standardized workflows that we developed, leveraging the video platforms that we're supporting, we can't control the experience. We can't make sure that we can track utilization, that we understand visit lengths. We're not getting the data that we need to improve and make investments where they're needed. So I think we know that there were technology challenges across every video platform at the peak of COVID. I mean, you had challenges on your Zoom meetings, your WebEx, like whatever your video platform was, like no one was ready for a pandemic. And definitely no one was ready for the shift to virtual. So I think that what we learned really, really quickly was that we needed to invest in our monitoring systems. And we needed to be flexible as an organization with our providers. And, if picking up their iPhone and making that connection was easier and helped them secure that visit and make the patient feel safe and cared for in the moment, then that was okay because of the time that we were in. But now that we've made some investments in our video platform, and we feel really strongly that we're moving in the right direction to support the scale of telehealth now, we want to kind of drive everyone back to those standard workflows. I think anyone who doesn't have a video platform partner or an integration with an EMR, like that's really the next step. I think relying on your FaceTime, your Android, Google Home, whatever you're using for that video connection, like make sure it's secure, make sure it's through kind of the systems that you can manage and that you trust for your patients and providers. We've already started that transition. I don't think we ever stopped. But we definitely had flexibility in the beginning because it was necessary, and now that we're really driving towards standardized systems.
Well, that's great. Brian, what about from a payer side? Have you had to adapt in any ways, whether from a data perspective or other workflows on your side from a technology perspective?
There's a lot of operational considerations internally to drive benefits and claims and all of those. I won't bore anybody with those details, but when we talk about integration with vendors and network and interoperability, that's a big concept that I think is very important, and Sarah touched on it. For one, our platform with Blue Care, one of the first things we wanted to do is to have every one of those visits dumped into our data warehouse to be utilized by our provider network if they're connected to us. And I think that's a standard we'd want to apply to any future vendor partner, as well as some of our network partners who have that capability. And that is to make sure that these visits are portable and in the record and available to the member and the provider that member is going to see down the road. That's a pretty difficult thing to put all together. And then what happens when that person changes their plan? Because people do go to other employers, other payers, and may come back to us at some time. So that's a hard concept to wrap your mind around, is this portability of that health record and maintaining interoperability with our network and specifically vendor partners we want to choose.
I think the last piece on the technology, and I'll speak a little bit in the community space and kind of what we're seeing in our data as far as health disparities go. And we still have, believe it or we still have work to do in some of our communities where we know that we have health disparity and where we know that there still might not be good broadband access. And, we're seeing those pockets, whether it be in rural or whether it be in the urban areas, and really diving in and digging into what's going on in those communities. What is the barrier to the access? Is it a socioeconomic or cultural thing that we're not comfortable with video care yet? Or is it that they truly don't have the internet access to provide that? So, working through our community health centers, working through our community partnerships to understand that, and whether that may be just providing a space where somebody does want to seek care or seek care virtually, a space to go and do that in. We're thinking about options like that, but really looking into some of our data and how do we hit those areas where we know that we have need and chronic disease, but not seeing potentially utilization for access as well.
All right. Well, great. Well, we're just about at time here, so I guess to bring things to a close, I just want to thank you all for your time this afternoon. I really appreciate you sharing your insights and your experience with our audience. I thought it was a rich conversation, and I know I learned a little bit along the way. So thank you so much. And I guess at this point in time, we can pass it back over to the conference coordinators.